Rachel's going to present this over the next 5 minutes.
All right, thank you, Dr. McCarty. So this is just a case to put together everything that we just learned over the last couple of sessions. I still have no disclosures since this morning. So this case involves a 53-year-old female who had an acute right knee injury after a low-energy fall while skiing. She felt multiple pops at the time of injury. She was unable to ski down, ski patrol. This was at an outside hospital. She was diagnosed with a knee dislocation. She underwent a quote-unquote closed reduction. CT angiogram was negative for any vascular injury, and she was sent home with outpatient follow-up. She presented to our clinic 48 hours later with this injury, or with this presentation, I should say. Severe knee pain, inability to bear weight, and on examination you see this medial skin dimpling, unable to range the knee. So I guess I would ask some of our colleagues, what does this tell us when we see this patient 2 days after a popping injury, high energy down a ski slope? What do you guys think? Not reduced, right? Not reduced, and this is a dimple sign. This can be very challenging for what's going on subcutaneously under the skin here. These are her radiographs. Any thoughts on what you're seeing here? Still not reduced. Yes, exactly. So this is a bad problem for this patient. We don't know how long if she was ever reduced, and if she's been dislocating or subluxating in and out, or if she's just been this way since the injury. So her diagnosis is near-reducible posterolateral knee dislocation. She was admitted for further evaluation and for surgery, and we'll talk about the surgery. Her ABI examination was normal, and she was neurovascularly intact with no neurovascular injury noted. So an MRI was obtained, and I just have a few cuts instead of a video, but we can see some pathology really throughout the knee, even though these images are poor quality, no ACL, PCL, medial side. So she went to the OR for reduction of this irreducible posterolateral knee dislocation. I think the biggest take home here is looking at the patient. You look at the patient, you see their skin, and that's a problem. You hear their history, you're already thinking something with the knee, something high energy, something going on. And you have to be thinking about all these things that, not jumping to the surgery for ligament reconstruction, but what's going to make sure that we're protecting this knee, kind of like Dr. Vidal was saying, is a biologic kind of organ. So the more percent of the time that this patient's out of alignment, the cartilage isn't liking that, the meniscus isn't liking that, let alone any of the ligaments that may be injured. So when we go to the OR to reduce her, we do have some surgical considerations that we have to talk about. In this situation, are we going to do anything with any of the ligaments? Is it worth doing anything acutely to repair anything that may be repairable? Because if we wait down the road, then we're looking more to reconstruction versus a repair. With that MCL that I showed you that was injured, is it better to repair that now while we're already in the OR under anesthesia, or would it be better to see if that has a chance at healing, or if it doesn't, when we go back for any further surgery, to go ahead and reconstruct that? And I don't think there's necessarily a right or wrong answer for this, but these are some of the things that we have to be thinking about in this case. So in the OR, she underwent an arthroscopy. She had an open reduction of her arthroscopic assisted open reduction of her posterolateral knee dislocation. The knee was able to be reduced. And that dimple sign was again removed, which we were able to see. The MCL was not addressed at the time of surgery. Her post-op neurovascular exam remained unchanged. She had a stable knee throughout a range of motion from 0 to 90 with no gross instability. So these are her post-reduction films. What do you guys think? Good, reduced. So that's good. At least we're leaving the OR knowing what we're working with. So in terms of clinical decision making, we have a grade 4 posterolateral knee dislocation with complete injuries to the ACL, PCL, the superficial medial collateral ligament and the POL, as well as the posterolateral corner. Hard to discern all of this because I didn't show you a video from her EUA and I didn't show you all the cuts of the MRI, but you can trust that these were the injuries that were there. And then at the time of arthroscopy, she was also noted to have a medial meniscus tear. So now what do we do? So now as surgeons, we have a lot of decision making to do. We have to talk to our physical therapy colleagues. We have to talk to the patient about her goals and expectations. Again, she's 53, but clearly athletic, wants to be skiing, and she has a desire to get back to activities. So in this case, the decision was made to do 6 weeks of prehabilitation, or I guess you could call it rehabilitation as well, because she had just had this surgical procedure to reduce her knee. She was able to get her range of motion up to 120 degrees in a hinged knee brace. She had no further descriptions of instability events, and the surgeon that was managing her was preparing for surgical reconstruction. So when we talk about our surgical plan, we've got a lot of different options. We've got a lot of ligaments that are out. We've got a lot of grafts that we may need, and there's many different ways to do this and do this correctly. As was mentioned in one of the previous talks, there's a lot of case series on multi-ligament knee reconstructions, posterolateral corner reconstructions, but there's really no gold standard for what we can do in any given situation. So this is one of those interesting cases that, like Dr. Wolcott was saying before, makes surgery fun. You have to do a lot of thinking on the fly, and there's no right way to do it. So in this case, the patient underwent the following reconstructions, all done in one surgery. So she underwent an ACL reconstruction with a patellar tendon allograft, a double bundle, posterior cruciate ligament reconstruction with 2 allografts, including an Achilles allograft with a bone block. She underwent an open MCL reconstruction with repair of the POL using autografts from her same knee, using her hamstring tendons. And then she underwent a posterolateral corner reconstruction using a split Achilles allograft. A lot of hardware. These are her post-operative films. As you can see, this is a lot of trauma for one knee, and she's already had a lot of trauma in one knee. So prolonged rehabilitation course, this is not going to be an easy recovery, and ideally we can get her back to skiing, if nothing else. So happy to take any questions or comments. I also have another case if you want to do that, or we can wrap it up.
Any questions? Ligaments? That's a pretty fancy case. I thought that was from the trauma hospital in Seattle.
That was at the level 3.5 Rush Trauma Hospital, but it came into Dr. Bush Joseph's clinic with that dimple sign, and we all were saying, this is a problem.
Nice.
Yeah.
And how quick did they get to the OR?
We got to the OR, I think it was that night or the next day. Yeah, he has some pull there.
Nice case. Thank you. Good job. Good job. Hey, all right, good.